We're going to have a discussion focusing on MDS and anemia in lower risk MDS. I am Hana Safah, Professor of Clinical Medicine at Tulane School of Medicine, as well as the Director of Stem Cell Transplant and the Heme Malignancy Program at Tulane. Joining me are my colleagues.
Hi, I'm Jamile Shammo. I'm Professor of Medicine and Director of Bone Marrow Failure Program at Northwestern University.
Hi, I'm Andrew Brunner. I'm an assistant professor at Massachusetts General Hospital and Harvard Medical School in Boston, Massachusetts.
Hi, I'm Tiffany Tanaka. I'm an associate professor for the Division of Blood and Marrow Transplant at UC San Diego Moores Cancer Center.
So let's go through these abstracts that probably are going to shed some lights on it. And I'm going to start with Dr. Shammo here and talk about the first abstract is the impact of genomic landscape and mutational burden on primary endpoint response in the COMMAND study.
So I think I'm glad to finally see that MDS is being categorized according to the molecular characteristics of the disease. So I am hugely in support of utilizing SF3B1 as opposed to ring sideroblasts, without a doubt. But I think all of us want to know, how does the response to luspatercept differs in patients who may have an additional mutation on top of their SF3B1? And that was not something that was reported on up until this year's ASH. And Dr. Kormuchi and colleagues from the COMMANDS trial looked specifically to answer that question. Does the mutation burden matter when evaluating responses to luspatercept or EPO for that matter in that clinical study? So patients who went on that trial had to have baseline analyses, and included in that was next generation sequencing. And so I like to think of this, or the way the results were reported actually were relative to ring sideroblast positive versus those who were negative, and then comparing their responses to either treatment depending on the mutation burden at baseline. So I think it's, as we all know, most patients with MDS will have at least one mutation. Some had two, some had three, some had four, and interestingly, a lot of patients in the luspatercept arm had more than 4 mutations compared to those who had EPO. So granted, the stratification didn't happen according to mutation burden at baseline, but nevertheless, these are data that we are being presented right now. And what's interesting is that if you looked at the RS positive group, the mutation burden, even though it may include poor prognostic mutations, didn't really affect the response. So you continue to have a sustained similar response to luspatercept, irrespective of the mutation burden. On the other hand, in patients who had RS negative disease, mutation burden affected the response to EPO, okay? But that when you compare both treatments, luspatercept and EPO randomized patients had the same response rate taken all together. So the good news, I suppose you could say, that mutation burden will not affect response to luspatercept, and these are really novel and interesting data. So the hope is that this will continue to be the case now that the drug is approved in frontline in real-world setting.
Thank you so much. That's very helpful. And I think, if I may add, it's number one, it's we have a drug that's going to work, but also it will help us understand, maybe with more studies, understand more why do we see something different in the RS negative patient compared to the RS positive patient, and what can we add to that? And I think there will be some light to that with the discussion soon.